a representative from almost every CHNA. So it'll be a chance for you to really get a perspective on what's going on across the state. We have been working in an Inter-CHNA capacity for quite a few years, and so now we know what each other are doing in our regions. And out of that actually came this need or request from CHNAs to even know more. So they were pretty happy about what they were finding out from each other in their own regions. They said, oh, I wonder what we're doing, you know, what are they doing out in Central Mass or you know, the Northeast or the Southeast. So we, about a year ago, a group of folks asked to convene to talk about how we could think about even doing more sharing and work together on a statewide basis. So that planning's been going on for about a year, and as part of that planning, it was decided that we needed to really get more input and sort of see what's happening and get the feel for it all. And so we decided to convene this leadership group today. And I really want to thank the people that helped to do the planning. We put a lot of work in. We had a lot of spirited conversations. And so I was wondering if the folks that helped with the planning could please stand up to be recognized. The folks did a lot of traveling to do that. I also want to thank Judy and Amanda from HRIA who helped to facilitate the meeting. Amanda's probably outside, so she didn't hear us thank her, but we'll pass it along. Today is, I think, will be a very, hopefully, invigorating day for people to talk with each other, to get to feel what each other's doing. And it's also an opportunity for us to think about how we might do this work in the context of a changing public health environment. So those of you that were at the conference yesterday heard from our keynote speaker that, you know, we have to continue to move forward in public health, to think about new ways to do our work, to develop new partnerships. And so at the Department of Public Health, we're also thinking about that. You heard a little bit about the commissioner talking about some of her priorities. And today, Eileen Sullivan, who's Chief of Staff, will talk a little bit more about the commissioner's priorities. The commissioner is also making his presentation today down in, where are they? Down Barnstable, to the health officers. And so at the same time, you guys are probably also going to hear it, which is a really good thing. So before I turn this over to Eileen, I just want to recognize someone who isn't here today, who I know would be here and would be very enthusiastic about today, and that's Peter Lee. We talked a lot about him yesterday, but I didn't want today to go by either without mentioning him and the contributions that he's made to all of us in the CHNA world and in the healthy communities world. And we miss him, but I know his spirit continues to inspire the work that we do, and it will for many years to come. So I'll turn this over to Eileen.
So as Cathy said, I'm Eileen Sullivan. I'm the Chief of Staff at the Department of Public Health, which I began, I think, a year and 3 months ago. It's been a really calm time at DPH since I took on that job. I was joking with somebody earlier, I've had 3 commissioners and 6 changes of letterhead. So we've been through a lot of changes. But luckily now we are, hopefully, in a place of being stable as a department. And Commissioner Bartlett has been officially on board since the end of June and is moving ahead with some changes at the department, which I'm going to talk about a little bit today. So as Cathy said, the commissioners actually at the Mass Health Officers today, and when we learned that you all were meeting, thought it would be good to share some of the same information with you. Thank you, David. So really right now, kind of where the department's at is focusing on three very important things. One is the regulatory functions of DPH, obviously after what occurred last year, both with the forensic drug lab and meningitis. It was critical that we look at our regulatory responsibilities, in particularly areas where budget cuts had led to not having the appropriate staff in place. We were very fortunate this year in that Governor Patrick's budget and the legislature did give us additional staff, both in healthcare quality area and the Board of Pharmacy, as well as our environmental health, including food protection. So we're really working on that area intensively. We're also looking at the DPH infrastructure. Again, just like many of you at the local area, with budget cuts happening, key positions changing, just really looking to make sure that we've got the right management structures in place, the right quality assurance, that we're looking at how we're supporting the agencies that we fund. We actually have a group now of about 20 agencies that are in some kind of financial distress that we're working with as an entire department across bureaus to support. So again, just looking at those kind of key infrastructure issues. And then improving partnerships and community engagement is a high priority of the commissioner. For those of you who don't know her, she previously had been the bureau director at the Bureau of Community Health and Prevention, and so she has worked on these types of issues for most of her career, as well as being a nurse. So one issue that we've taken kind of a structural change to is establishing the Office of Local and Regional Health, which the commissioner actually thought was this really great idea she had that turned out actually existed 20 years ago and was cut during budget cuts in the early 90s. So all the things come around again. So the goal is to establish this office to be able to provide technical assistance to the local boards of health and health departments, as well as provide regional support. The office will be under the supervision of Associate Commissioner Suzanne Condon, who's also the Director of the Bureau of Environmental Health. Jana Ferguson will be serving as the Director of the office, and the 5 regional directors in the 5 regional offices will report to Jana. We'll be working with our partners, MHOA, MHB, etc., on really identifying what do local boards of health need. We don't have any new money or resources, but we can look at how we realign things, and we can also look at how we communicate in the department and how we can do that more effectively to work with local boards of health. And then there's the issue of community engagement, which of course is why you're here today. So going, kind of back to 1992, and some of you in the room in 1992 might have not been thinking about public health very much. I was actually working in the cities of Cambridge and Somerville at the time for an agency called CASPAR that was doing substance abuse, and I was a training specialist. And I remember being told to go to a meeting, make sure I volunteered for nothing unless they were going to give the agency money. And I think that was the norm. That's how people acted in 1990, 1991. So the concept of CHNAs at the time was groundbreaking. It was just, you want us to all get together and talk to each other? At least in Cambridge and Somerville, nobody was doing it. So the state was divided into 27 areas. The requirement was incorporated into the contracts, along with this novel requirement of using data for health planning. And it's been over 20 years. So some CHNAs thrive, some struggle, a few have stopped existing. And it's been, I think, quite a ride for some people figuring out this work. But there have been a lot of changes since then. Collaboration has become more the norm. In some areas, obviously, struggle more than others. I worked for a number of years in the department in the tobacco prevention program and got to travel around the state, and I think I've kind of been everywhere from the tippity top of, where was it, Heath, which I think has like 97 people, all the way to the major cities and doing that work, and I really got to see a lot of the ways people work together. And there's still areas where it's tough to get everybody in the room. But people know that collaboration is the right thing to do, and many of us are doing it really well. Nobody would think about doing health planning without using data, and people are using it actually in incredibly creative ways. Nonprofit hospitals have to do community health assessments, and again, there's more and more pressure on doing those well. And then there's the whole issue of policy, environmental, and systems change actually being the way to improve public health, which again, if you go back to 1992, who was using those words or thinking it would actually work, or that you could do things like make bars smoke-free and improve people's health? I mean, I would have laughed if somebody had said that in the early 1990s. And most of this policy work, as you all know, happens at the municipal or the statewide level. From certainly from DPH's perspective, continuing the policy work, really focusing on what is the policy and environmental change is going to improve health outcomes is a high priority. What's gotten complicated, I think, over the past, particularly 10 to 12 years, is the different partners with the different municipal and regional needs. So DPH has funded a wide variety of programs, mass in motion, tobacco, substance abuse, and other issues to create policy change at the municipal level. In doing that, a lot of the municipalities, sometimes they wanted to, sometimes DPH made them because of lack of money, grouped together in all sorts of different collaborations, and often not the same one. So a particular community may be working together on tobacco, but not working together on mass in motion and working with somebody else on substance abuse. And so again, a lot of different types of partnerships forming, sometimes driven by the money available. And in all honesty, DPH not always providing clear guidance or coordination between bureaus about how those grants were being given out and the groupings were happening. Board of Health districts have formed. Again, that was a very strategic area that DPH has worked in using federal funding. We have the Regional Emergency Preparedness Coalitions that have been around now for a good 10 years. We have new partners in the regional planning councils and agencies, particularly around the work we're doing with mass in motion and trying to work on transportation strategies. And again, they have totally different kind of groupings that they work with. And then hospitals keep merging, and as they merge, they create new service areas. And so we've ended up with, this was the best I could kind of do, all these crazy maps of how people work together. And so one community could be doing lots of different configurations depending on the issue and depending on who's funding it. I'm going to somehow get this into a better slide, but this was the best I could do quickly. So currently, DPH staff are having conversations about how can we best support partnerships at the local level, and how can we best support health planning. One of the steps that we took in early September was to conduct a survey that we sent out, got nearly 700 people to respond in less than 2 weeks, right after Labor Day, which was pretty amazing. And what was really clear from that survey was that the majority of people who responded at least, are very involved in local partnerships and value them. 92% of people said they would participate even if it wasn't required, and 82% are participating because the coalition they're involved with is achieving important outcomes on an issue they care about. So again, just clearly showing the value of this work. Moving forward, one of the decisions we have made is that DPH contracts will require collaboration, which they have since 1992. But we are going to allow the local agency who's applying for the money to decide on what's the most effective collaboration. We really feel like we need to align the requirements with more than one entity because there are so many different successful collaborations, and that we sitting at DPH don't know what's going to work best for a particular community to achieve health outcomes. So our, I guess our statement would be that we support participation in CHNAs, coalitions funded by DPH, federal and private funded coalitions, and any other community-based coalition that's working on improving health outcomes. And so the questions we're asking ourselves and looking for input from the community is, what is the most effective role for DPH in supporting community and regional collaborations? Unfortunately, what people want most is money, and we don't have that much of that anymore to give out, and we're not seeing signs of money coming down in huge buckets unless it's medical marijuana. It's maybe the only place where we have lots of money at the moment, which was never one of our priorities, needless to say. So what can we do as the state health department? What is our role in supporting? What is the way that DPH can best share data with all of you, technical assistance, and best practices, so that people can learn from each other? Again, some of what you're doing today, learning from each other. What's the best way to do that with everybody? So we don't know the answer to either one of those questions. We have some ideas, but we're not sure what the answers are. We're currently in November having small group discussions with our staff to have input, again, across bureaus and around the state so that we can share ideas among our staff. And the commissioner will be beginning a series of community health dialogues in mid-November, and we'll be going to 8 different locations around the state and doing a presentation that will include some updates on some things going on at DPH, but also the slides you just saw, with maybe a better map slide than what I created quickly, and asking these questions and inviting people to respond to them. So you kind of are getting a preview today of what will happen in November. And our hope is to gather that information, the feedback from our staff, and then to be able to work on coming up with a framework and really looking at how our resources are being used department-wide. Not all of our 10 bureaus interact with the community. Some of them, like laboratory science, have very discrete roles, or healthcare quality. But the majority of our bureaus have some interaction. And one of the things Commissioner Hartley really wants to see coming from being a bureau director is how the bureaus can work together effectively and have some clear guidance as commissioner and expectations about how all parts of DPH are working with the community. So that's what I have for today in terms of information to share with you, and I'm glad to take questions. Okay, David.
I'm just going to stand.
And I don't know if everybody knows everybody. Maybe you want to introduce yourself to the group when you have a question.
Hi, I'm David Aronstein from the Boston Alliance for Community Health, CHNA 19. I've been in my position for 3 years, and in the 3 years that I've been here, the technical assistance that the CHNA got from the Centers for Health Communities disappeared because it got moved to Mass TAP. The regional directors who were reporting to the Health Communities director are now going to be reporting to the environmental health. As far as I know, CHNAs get no direct funding from the Department of Public Health. We have this odd relationship of depending on the hospitals in this VON process that DPH is responsible for, but it's confusing. And there's no enforcement, as far as I can see, of this requirement about DPH contractors participating in CHNAs. So my question is, what do you see as the realistic future for CHNAs?
Well, I think that's what this conversation is exactly for. I mean, again, if you go back to 1992, the vision was to get people together and to see what happens. Would CHNAs be self-sustaining over time? Some are, with the community partnerships, and some CHNAs haven't survived. So I don't think there's a one answer fits all. If a CHNA is doing good work and the community is embracing that and the hospitals are seeing that as a way to achieve health outcomes, then funding is going to, flow in that way. I don't see funding realistically coming from DPH. There really never has been funding from DPH. There was at one point, I think, $5,000 in mini grant money, in the 90s. Certainly not money that supported staff at any point. So again, there would have to be some real shift in funding for that to suddenly appear after all this time. In terms of the requirement, you know, as I just addressed, we don't think the requirement is necessary anymore. If people find that CHNA work in their community is helping to lead to the outcomes, they're participating. If it's an area where that's not happening, then there's really, it's not effective for DPH to be saying you have to go. I'm not sure it ever was effective. In the beginning, it definitely got everybody to the table. Again, I know working at Caspar and then I worked for the city of Cambridge, it was like you have to go to the CHNA, and people went. People stayed if good work was happening. That's the reality. What we are saying in our contract is people have to collaborate, and they have to tell us how they're going to do it. They may choose a CHNA as a way to do it. They might choose a substance abuse coalition, depending on what they're working on. And again, we don't feel we should be saying this is what's going to work in your community. That's really unique to each community. So I'm not sure if I answered all your questions in there. In terms of the regional directors, it is going to be a transition. The goal is that they still will provide support to community coalitions, as well as to local boards of health, and that hopefully it will be more of a 50-50 kind of sharing. Right now, we're not providing any support to the local boards of health in terms of regional support, and that's just too lopsided. So we need to balance those two things. Yep.
You used this word coalition several times. I'm Barbara Nealon, I'm from CHNA. You mentioned about, again, being able to utilize some of these extra coalitions. Do you think that will be defunct? As far as if another coalition wants to come in and do the work in our area, would we be competing for those resources?
Well, I don't think it's necessarily a new coalition coming in. It's what already exists. So I'll go back just to using my own where I live as an example, which is Somerville. So in Somerville, there's a CHNA for the Cambridge-Somerville area. There's Somerville Cares About Prevention. There's Shape Up Somerville. There's Healthy Somerville, funded by the Cambridge Health Alliance. So there's all these different groups. They actually get in the room together and talk to each other. You know, the CHNA is one piece of that. And so again, it's going to depend on each community. But I don't see, we're certainly not funding anything new that's going to come in. I think again, it comes back to, for CHNAs, there's some CHNAs just have phenomenal success. I'm looking at David videotaping me here with his years of working in Fall River and the tremendous policy work that they've done, you know, just was completely intertwined with the substance abuse funding, the tobacco funding that came from DPH. So if that kind of partnership is happening, that's ideal. If people are isolated and not working together, then the community has to decide where they're going to go and who they're going to work with, and ideally somebody would emerge who can really provide leadership in the community. But again, we don't think DPH should be saying who that is in the community. Yep.
Wendy Garf-Lipp from Fall River. I think that one of the things that we see and we vision for the future of the CHNA is that the CHNA does become that entity that brings together all the organizations you mentioned in Somerville, that they will all have a seat on the CHNA and that their work will be intertwined, and the CHNA becomes the governing body and the leading body in the community. And one of the, you know, you cite Dave Weed of being, you know, from Fall River, of being able to do that. And that perhaps the state communities are so different because there is limited technical assistance to teach people in the CHNA how to become that collaborating partner. And instead of just saying, gee, it's not working, it can't work in Franklin, or it can't work in Dorchester, how about working to try and solidify exactly how the CHNA connects to people, how they bring organizations to the table, and to provide that massive technical assistance that will teach people how to be better collaborators so that it can fulfill that function.
So again, what I would say in response to that is the state is not the same. And having done work with groups like in Franklin County, for example, or more rural areas or suburban areas of the state, then I think Fall River has the hub of the city there that brings people together. In some place like Franklin County, where you've got, 30 different local governments, boards of health, all that we need to pass individual policies, I frankly don't think the CHNA model for a county works.
works on the Cape.
I was just going to
Different
say, I
people have
beg to differ
different
as the
opinions.
chair of the CHNA in the Cape and Islands, and I've been the CHNA chair for probably 10 years. We have both islands are represented, we have representation all the way up to Provincetown and down to Falmouth. We have worked very hard and strived over the last few years to bring as many partners in as possible and to show them the value of being a CHNA member. And we've been very successful at that. We have general meetings that are upwards of 40 people every single month. And they come from all over the Cape and Islands. So the county, it can work as a regional, county-wide. It takes time to form those relationships, but the Cape has been doing that for a really long time and is very successful at it.
So I will say we hear very different feedback from different sectors in the community. And again, this is not meant to be a debate today. It's meant to be the beginning of a conversation. And one way people participated in that was the survey, which had some very interesting feedback in it. Again, it was clear in the survey that many people value CHNAs. It was clear that people value other coalitions as well. And basically, the survey results will be made public next week on our website. If people want to see the more detailed data, glad to share that with you. But again, it's getting to look at us not saying this is the one answer. Where CHNAs are successful, we are totally supportive of that. But we're not going to say to areas of the state where they haven't been successful that they need to have a CHNA, particularly if something else is working well in the area. And again, I invite you to think about these questions and think about your responses to them. We will have both the opportunity for people to give feedback directly to the commissioner when she goes out, and we'll also be setting up an email that people can send their thoughts to.
Can we share these questions with members of the community?
Sure. Yep.
Hi, I'm Pat Milano. I'm with the Boston Alliance for Community Health, CHNA 19, and I also live in Suffolk County, which we call CHNA 19 Light. So that's Revere, Chelsea, and Winthrop.
I used to work in Revere and Chelsea.
Yeah, here we go.
I went to that light CHNA meeting for a number of years.
Harbor Community Health
Yes.
Alliance, yeah. Data, sharing data.
Mhm.
Is there a reason why we cannot get real-time data from DPH? There are other sources, that provide
data. What do you mean?
So it seems like we're always comparing current data to data that's 2 years old from DPH, and we never seem to be comparing 2013 data with 2013 data. It's always 2013. We're comparing it to 2011 data. So I'm just wondering if there's been any thought about how DPH can provide us with data that's more current.
So most of the data that we gather, we have to wait to get it. So for example, death data is a perfect example. Right now, we're actually in the process of hopefully going live in January with a module that will allow locals to put their death data directly in a website. For years, we've been dependent on people mailing us the information and then us needing to put it in a database, and some people take a very long time. And so that's why it's taken a long time to get death data. So this new electronic module will definitely speed up that process a lot, but of course people have to use it at the local level, and that will be a learning curve for both the local boards of health, hospitals, funeral directors, etc., to use it effectively. But ultimately, it is by having electronic systems, that the data can become available quicker. Yep.
Lisa Guyon, CHNA 27, Cayman Islands. Is DPH looking at any other models, any other statewide models that are organizing regionally that we could use best practices from?
There isn't anything right now that we're looking at. Again, it's a question of looking at what we're currently doing and learning from that, as well as asking people what they think might work. I will say Obviously collaboration regionally is very important, particularly for sharing resources when we look at funding. In terms of actually doing the policy work, again, it needs to happen municipality by municipality. We can certainly do things to build an environment that's supportive. Again, I was very involved with the Clean Air Works movement and trying to get people to do smoke-free bars. And it was helpful, having Cambridge and Boston and Somerville and other towns say they were all going to do it together. But at the end of the day, each municipality had to pass their policy individually. And that's where the policy work happens, is at the municipal level. Or it happens at the statewide level, in which case there are very effective groups like Mass Public Health Association that I would encourage you to partner with, or specific coalitions, Mass Suicide Prevention Coalition or Tobacco Free Mass, if you want to work on a particular issue. I don't think there's a need to create a new statewide coalition when we have so many effective groups in Massachusetts already, but rather to partner with them. And again, DPH doesn't fund those groups, those advocacy groups that are doing statewide policy are not funded by us. Yeah, Clara?
Eileen, as you say, policy change so much. As you say, not only commissioners, but federal policy is changing all the time. So we are very much at the mercy of wherever the funding is coming from. But even with that situation, the CHNAs has been demonstrating sustainability and stability in some places better than others, including the NIDA. But 27 years of existence is not an easy thing, just drop it. And also the other piece that I would like to emphasize is CHNAs, if there is a tobacco coalition, we are there. If there is a suicide prevention, we are there. But if suddenly the funding changed to a completely different subject, let's say environmental health, we will be there. Because if you like it or not, the people locally are the same, the ones that are involved in the different coalitions are the same. So I will ask the department to think clearly about how to keep the good things that the CHNAs have for such a long time, rather than say, well, you are on your own, you survive on your own, you do whatever you have to do to survive. But say, okay, we have something good here, let's use it in a different way, and not necessarily money has to be the only way, but at least recognition of the role of the CHNAs. That would be very valuable to us. With that, we can go and get funding. And also guidance, because I think if you like it or not, the Department of Public Health is providing a lot of guidance about focusing. We have so many issues. We can focus on different issues. Now, health is not going to be only DPH, it's going to be mental health. It's going to be consumer affairs. I mean, consumers are going to be taking a big focus from now on according to healthcare reform. So CHNAs has to be extremely valuable because we are already on the ground. So I just want the department to think about other ways, not necessarily just from the DPH, but from other departments too.
Right. So again, I would say in response to that, the department completely recognizes there are well-functioning CHNAs and we are completely supportive of them. The simple thing we're saying at this point is we're not going to say to an area where the CHNA is not meeting, or where frankly the CHNA is not robust and is not working on policy work, that people have to participate. What we're saying to people is you need to participate and collaborate locally, and leaving it open. So if those areas where a different model is working, where for example in Franklin County, there is a very active substance abuse coalition that does bring people together. And that serves a very similar role perhaps to a CHNA in a different community, but it's not a CHNA. We're not saying that's not valuable. And again, we're saying some of it depends on the local perspective. So you had a lot of good comments in there, and I'm not sure I'm going to respond to all of them. But This is very much a conversation.
Yeah.
We want to hear what people's thoughts are. We want to hear everybody's thoughts. And we have limited resources at the end of the day. So we're trying to figure out the best way to use them. Your resources have traditionally come, from Cathy and the regional directors, but DPH has 10 bureaus that do have funding decisions they make and do work with coalitions. And what Commissioner Bartlett wants is to look at that big picture and have a more unified DPH approach. And we don't know what that looks like. We really don't. That's one of the reasons her style is very much one of asking questions and asking people for input. And that will happen through these kinds of discussions, through the community dialogue, through our staff talking to each other, which hasn't happened yet. And then that will kind of, be dealt with by a small group at DPH and shifted through, and then we'll come up with a framework, and then we'll bring that back out to the community and get more feedback. The only one thing that's definitely changing is a requirement that frankly hasn't worked and has caused confusion. We are reframing. Yep.
So one of the reasons why many of us travel 2 hours for each meeting to come together for this statewide Inter-CHNA is because we recognize the potential power that we would have in the world of advocacy. When my CHNA speaks out on its own, it makes a ripple. But when 27 CHNAs band together and we speak out, then we are a force to reckon with. And I think that that is a powerful tool for DPH to be able to put in their toolkit. I get what you're saying about Franklin County. I understand that not every CHNA is functioning. But I'm also concerned that we take communities and we put in a coalition that in essence is a one-trick pony, that has one particular issue that they deal with, and do not get the diversity and the scope of service that a CHNA brings to the table. What makes the CHNA work is that the Tobacco Coalition is sitting there. The substance abuse people are there. The homeless people are there. That's what makes it work. And I understand that it might not be working, but before we throw the baby out with the bathwater, maybe because we now have this statewide structure, maybe we can do some work to try and strengthen those CHNAs that maybe are not yet functioning. And if they don't get strong, then fine, then we move on. But at least let's make the effort to take what we all know. We came today with these great boards saying what we do well. Let's share that information with people that are not here, especially the CHNAs that are not here, and the CHNAs that are weaker. And let's make that effort to come together and teach what we can and strengthen each other so we have that advocacy voice as we move forward.
And again, what you're saying in terms of sharing the successes and everything that's worked really well is something we totally support. But we do want the conversation to be open to everybody. And so in some areas that may include groups that are not CHNAs.
Absolutely.
Because those are the groups that are working well in that area. We absolutely do not want anything to stop that is working well. We want to support what's working well. But we also don't want to create this, what in all honesty has been confusion for people of this contract requirement, when in some areas there is no CHNA to even participate in. Yeah.
What about just encouraging people to participate in an area where an CHNA exists?
Well, and again, the language we're planning on using, let's see if I can get back there, is that we support participation, and CHNAs is the first thing listed on purpose. We support people collaborating. We support people working together to change health outcomes. Again, if people only are coming to your meeting because it's a contract requirement, that's not happening in Fall River, right? People are there because it's working.
I don't think that's happening anywhere. I think
We
that
have
there are plenty
received
of people-
feedback from people that they are only going because it's a contract requirement. The commissioner has had that conversation with people.
What does that mean?
That people are only going to the meeting because there's language in the DPH contract that says that they have to go.
Sexual
They
assault.
have a
I can say the
DPH
sexual assault contract.
Okay, but is that like a percentage?
So DPH has thousands of contracts, so substance abuse,
I'm not aware of
HIV.
anybody in our CHNA that comes as a result. Maybe we're-
So again, then this doesn't even impact you one bit. If your CHNA is functioning well, this shouldn't impact you at all.
Functioning well or not, I just didn't know.
Right.
That's never come
But the original CHNAs were literally people had to come and there was a little checklist. And I think we've moved beyond that.
We have.
And that's what the commissioner is basically saying.
Yeah, but why are we operating sort of under that,
Because it's in the current DPH contracts and it's causing confusion.
I think sometimes.
Because it's
people might
language that was
start out
written.
thinking that way,
Yeah.
because of that, but they stay
Mhm.
because there's something valuable at
Exactly.
the table.
Exactly.
So I'm reading from CHNA 6, but I had a question about this Office of Local and Regional Health.
Mhm.
This is a new regional office here?
Correct.
So there's a great opportunity, I'm thinking, under Suzanne's leadership to include CHNAs, or maybe have an advisory group of CHNAs to have the same information shared. So there's going to be inconsistencies, but at least everybody's starting off on a level playing field as far as what they're getting from the state information technical system. They can say, yes, they want it, then they don't. But not even knowing what's available is, I think, sometimes the issue.
Right. But again, that's part of, we're still very much in the early formation stages.
As that's going.
Yep.
This may be something that supports the CHNAs
Mhm.
and also elevates them to a position where people know that, yeah, this is the group I want to be involved in. I mean, I don't think that people have negative impressions of CHNA. I think it is more the confusion or not really understanding, what it is. I don't think we should hide. I think we should just
Right.
figure out a way to promote that.
Mhm.
Maybe this office is would be great leverage to do that.
The other vehicle, which we're still trying to figure out the best way of using a pot of limited resources, is the new Community Health Institute. Am I saying that right, Steve? Which HRA is leading. And again, we're still in the early formation stages of that group, but obviously they're organizing a training for you today, trying to figure out the best way of, again, bringing DPH resources across bureaus who are working with the community together to fund that institute and provide training and resources. Again, we're still sorting that out in the department. But that's another tool that we can use.
Available to every community. I think people would go, oh, here's something real.
Mhm.
You know.
Yeah. Yeah.
Hi, I'm Teresa Glenn. I'm with CHNA for Greater Springfield CHNA. We've been in existence for, as with everyone, one of the pilot CHNAs. I'm glad to be here today. I wanted to share a couple of thoughts. One, and there sort of may end up being a question, may not be, might be a suggestion. Yesterday,
And Shelley and Ron are diligently taking notes for me back there, so they're getting all your
I
suggestions.
really enjoyed being here, and especially with healthcare reform really moving forward, and also learning about the work of colleagues here in the room, CHNAs in the room, which was awesome too. And one of the things I heard, we all heard a lot, but one of the things that really struck me was there was expression that how do we reach the population, quote unquote. That we know how to write policy. And now I'm talking we as in governmental.
Yeah.
This is a policy coming from the government. We are in support of it. We didn't write it, so we don't have that ownership on that level. But we have the law. We have the next level, which is now moving into the states, to implementation. And now we're moving to, okay, so how do you make this law work? And so that's a question that everybody's now starting to ask. It might be, though, that would probably have been a good question to start with in the beginning, and I sort of expressed this from being involved in the implementation of the 2006 healthcare law here in Massachusetts as far as people enrolling. So what I'm trying to say is that there's a lot of expression about how you reach the community. This is a room of people who've spent years and years being intimately invested and care about the community in a way that you have to, because sometimes it's, you have an ebb and flow in communities. Sometimes you learn to love the meetings with 2 people and the meetings with 30 because they're all valuable. Every single one is valuable, every interaction. And one of the things about the CHNAs, it's based on principle and practice that started in public health understanding. And that's some of what was discussed yesterday, but there were people from schools of public health that said, we don't know how to reach the community. We don't know how to do that. We don't teach people how to do that. That really struck me because when I went to go to school for community health education, it wasn't in school per se that I learned that. I learned that once I was brought into the community and worked in the community and had the opportunity to work with community organizers to do the work in the community. Then I changed. My understanding is like, yes, this is what I want to do. This is what I believe in. So I'm saying that, you know, David Mulligan is not here now, and things change, and with each new administration, we all experience the change. There are some things that I would just recommend going back to what started the CHNAs and what it is that made the department, which we value. I want to make sure, Cathy, wherever you are, that you know that when we say our relationship to the Mass Department of Public Health matters. I mean, it is such an important thing to be able to say, we have a voice, we've done work in CHNA that we could say, you know, we talk to, we have a relationship, a direct relationship, support. This is a connection that matters to the state. I love coalitions. I'm not against any group of people that come together to do something to change any issue or health issue in the world. Absolutely. But the relationship that we've had with you over these years at the department, it matters so much. And it matters that, you know, there's a lot of different opinions about how to do health and public health. And we are, unfortunately, money and who has the money and how to get the money and where the money is going is such an influence on how things are created and not created. I just want to remind people that we have a practice that was not expressed as in the meeting yesterday. People don't know how to do that. We know how to do that, so please use us. And please let us be part of the process. And as the department goes forward, don't, take the opportunity as the creation of the new departments are going forward, as the creation of the new vision. It's hard to be at the end of it when we're told, hey, guess what? We're not going to do this anymore.
So again, I want to stress I'm here today.
Can we speak up? So we can't, sorry, the people in the front, wonderful things being said, we can't quite hear you. In the back, that's okay.
So I do want to respond to that, saying in part, I'm here today for a reason. You're getting a preview a month early than the community is, so that you have time to digest this. And again, if you have suggestions, if you think there's a third question we should be asking or whatever, glad to take feedback. We are very much trying to engage people. I think, frankly, one of the things that makes this conversation hard is that there's been no conversation since 1992 when this vision came out. And different commissioners have come and gone, and none of them have engaged in this discussion. They've just kind of let things develop. And Commissioner Bartlett wants to engage in a discussion about this and what's going to work and what can be supported.
There have been discussions. There have been.
Not at DPH. The DPH commissioners have not done that since 1992. Nobody has. And said what's working, what's not working, what can we, let's have a discussion here. So I agree those discussions have happened at the community level. They've happened in different groups like tobacco. But the commissioner would like to engage everybody in that discussion and make sure we have a framework that makes sense for 2013 when we're engaged in policy work to change health outcomes. There's lots of hands up.
I just wanted to make a comment. Steve Ridini, I'm a facilitating leader, and as one who worked on setting up the original CHNA back in '92, Framingham, Milford, and South, which is a fascinating conversation. And what I'm hearing is a lot of passion. I'm also hearing, I do remember when folks came to the table because it was a contract requirement. In fact, folks were telling us that was the only reason why they were there.
Right.
And yet I also heard from this woman over here from the Cape saying the reason why people stayed was not about the money, it was about something else.
Exactly.
And it typically was about the work, it was the relationships, it was all the things that you're doing effectively. What I guess I just want to say to this group as we think about today is to think about what's been going on, what's currently going on in our environment, But the excitement is the commissioner, this is the first time I'm hearing a commissioner add a strategic direction about community engagement since the time of David Mullen. I have not heard a commissioner talk about it as one of their three major areas of work. So I guess the thing that we need to think about around community engagement is what is the model that works either in your municipality or your area? And to think about all that good work and then get to these dialogue sessions, these 8 dialogue sessions, and share that information. Because what I'm hearing you say, and I'm just thinking about this from my own perspective of working in CHNAs, is one is quite honestly DPH has this as a requirement, but there really haven't been a lot of resources to do this from DPH directly. So you've been doing this on your own in some way, shape, or form, either through determination of need dollars or other creative things that you do at the local level. So that's information that I think is really important to share in terms of how you've been able to sustain this work since '92. There are some really fascinating stories here that we need to talk about. And yet I also think this is an opportunity. I don't see this as a taking away. I see this as an opportunity to articulate and lift up what is currently happening, to think about there will be multiple models of community engagement. And you actually are sitting on quite a few of these, and these are things to share in these dialogue sessions.
Yes.
My name is Frances Hubbard. I serve as historian to CHNA Board and have been with the CHNA movement since 1990.
Cathy's just suggesting I pass the mic around, so.
Yeah, the mic, because people can't hear in the back.
Well, that's the only mic we have.
Thanks.
Just if you want to stop it, and then I'll bring it to somebody else.
Good morning, thanks. My name is Frances Hubbard. I work in Springfield, Massachusetts. I was as historian with CHNA number 4, which I've been with since 1994. I came into the work through a local public health department in Springfield, Mass. And what I wanted to comment on right now is we're using the term resource. And I think we may be thinking of resources as money, as part of money that sits someplace. And I want to caution us not to have an idea of resource as money, because it's so much more than that, in my opinion. It's history, and its ancestors, and its culture, and its values, and its the dynamics of the community. It's the politics of the period. It's what's happening in the world. And now we're in a world of cyberspace. And it occurs to me frequently that as we're talking in these meetings, that we're not forward thinking as we might be in considering who we are at this moment, both as individuals. Who am I as a resource? Who are you as a resource? And what is it that we could attain if we had the access to what it is the resources are? And I think that it's the people and their own history and their beliefs and so forth. And it concerns me when a department, especially public health in Massachusetts, the oldest public health department in the United States, is articulating perhaps, and I'm not sure, resources as we don't have the resources to do X, Y, and Z. When the fact of the matter is that we have the resources to do whatever it is we choose to do, whenever we choose to do it, and however we choose to do it. The thing is to decide to do it, and to decide to do it together, and to decide to do it cooperatively and with power. In relation to all the coalitions coming together, it gives me a little seed of concern. There's a little coalition in Washington right now, a little coalition that stopped the government, even though it was a minority. There's a little coalition that goes against the principle of the United States of the separation of church and state, that allows, and I'm frankly, not against faith-based organizations. Out of Springfield, the faith-based coalition of the American Public Health Association was born out of work that we did in something that we created called Parish Health Care. The very night that we gave the presentation of the APHA, that caucus was formed. So this is not an ideological discussion. It is not a sectarian discussion, but it is a discussion, I think, that could benefit from a truly, if we are really listening to conversations, let's not start the conversation saying, we are not going to do something, but we want to hear you talk. Well, why not sing?
I feel like we should stop because that was just such a good summary. And part of what I really, really want to support that you said, actually everyone support everything you said, but in particular that the resources aren't just about the money. And that's part of what we're trying to figure out because the money is limited. But the experience, the best practices, the lessons learned are things that we can figure out how to bring together and share statewide. And that's what we're trying to figure out. So thank you for articulating that so beautifully. I have no idea where we are with the agenda or time, or if somebody wants to take this over for me.
The next part of the agenda is...
Or if there are other questions that we should answer later.
Well, you know what we'll do? As a facilitator, why don't we, if there are other questions, Eileen, you're going to be here today.
Yes,
We have the
okay,
conversation some more. Okay. So first of all, thank you. A round of applause, Eileen. And a real round of applause to all of you in terms of your commitment to this work for the number of years you've been involved. And I love the idea of thinking about this as resources as opposed to just money. That is the element that's the crux of sustainability. Resources goes way beyond funding. It's about people, it's about in-kind support, it's about passion and commitment. So this next piece that we wanted to do with you is an exercise to get you up and moving and also to get dating today. So where's Wendy? I think you're going to help set the tone for the next part of this discussion.
So hi everybody, I'm Wendy Garf-Lipp from Fall River, Fall River Partners, CHNA 25. I think that for today, it's very important. I think I'm fine.
You can sing? Okay, can everybody hear Wendy? Yeah.
I heard that. So I think for today, it would be really great when you introduce yourselves, don't say CHNA 9. Because coming from Fall River, I have no idea what that means. You can say CHNA 9, but please also tell us what area that represents, so we have a sense of where you're coming from. So speed dating, I have to start with a disclaimer. I've never done speed dating for dating purposes. However, I've done speed dating for a really long time in a way to exchange information very quickly and very concisely and get an opportunity to talk to a lot of people. So it takes a little help in getting everything set up. So we're about 40 people in the room. Is that about right? About 40 people in the room. So what we're going to do is we're going to use these two rows. If you have more than one person here, then somebody has to sit facing opposite someone. We're going to ask a question. You're going to discuss, and then one row is going to move. So if you and your colleagues from your CHNA end up facing one another, that doesn't work. No, yeah, the question comes okay, so what if you should be over here? You're going to introduce yourself. You're going to identify the area where your CHNA is, say the name of your CHNA, and we're going to give you about 5 minutes to talk about each question. Then I'm going to ask everybody in this row. You're going to move around. The last person will come to this seat. You will all move over one, and everybody in this row will do the same, and then you will have a new partner. Okay? So is everybody sitting opposite a partner? We'll just pull those two chairs.
No. Yes, the other one. We have an extra
Alicia. More than one time. Tell me about the makeup of your CHNA. Who sits at the table? Who's interesting that's at the table? What interesting person or what interesting organization have you engaged? And who's missing from the table? Listen again. Tell me about the makeup of your CHNA. Who sits on the CHNA? What interesting people or organizations have you engaged? And who might be missing from the table? Begin by introducing yourself and talk amongst yourself. You have 30 seconds. All right, you start.
My name is Cathy, and I work I'm part of the CHNA Network, which is the greater series. organizations in the Tampa
We also do a retreat this summer on what's going.
People who are in the shifting line, shift one seat. That's what I want to hear, we'll vote. Everybody shift over one seat.
I'm Kimberly.
Shift down, please.
I'm Beverly. Hi, Jim.
Gloucester, all the way down.
Okay?
So Marblehead.
Don't forget to introduce yourself and identify your area. Here's your question. What makes your CHNA unique, and what's the most challenging thing your CHNA has ever done? What makes your CHNA unique, and what is the most challenging thing that you've accomplished? Unique and challenging. Talk amongst yourselves. Shifters, please move. You can go all the way. You got a long walk. This is the exercise. More of this. You already know the 10-minute debrief of some of the things that you heard, some things that you might want to share with the rest of the group. And I do encourage you during lunch and during the break time that you seek out people and continue these discussions. So, last question. Welcome to Wendy's utopian world. It's where I live, on a little cottage on the banks of denial. You have all the money in the world. You have all the resources in the world. You have no problem bringing people to the table. Name up to 3 things that your community could do to improve the health in your area.
Exciting way to start.
Wow. Table. Let's see if we can do this quickly. Back to the table.
The notion of having term limits is healthier for everybody.
No candidates. Whenever we do this, that there's going to be a whole bunch of people that don't talk, that just sit there. But clearly that wasn't the problem today. That we had lots and lots of alpha personalities in the room, and there was a lot of sharing going on. So we're going to take about 5 or 7 minutes just to sort of inform the group some of the interesting things you heard or unique things you heard. I could fill the 7 minutes, but it's much more interesting if you participate. So who wants to start us off? Tell me something you heard, something that was interesting. Tell us your name again.
Kevin Rudden, CHNA 6, Milford.
Okay, Kevin, go ahead.
A couple of the CHNAs I talked to shared a similar thing where you have one larger community surrounded by a lot of smaller ones, and the smaller ones think they have different needs than the larger one. It's a question of how you get them engaged or continually engaged and make them feel their needs are being met as well as the larger community.
Excellent. Not only is that an excellent issue, but the best part about what you said is there are a number of CHNAs that have the same issue. Exactly. That's what we have to connect about. Somebody else? What else is going on? Go ahead, Velma.
All right, so I'm Vilma from CHNA 11. That's Greater Lawrence area, north of Boston. The similarities was obviously one of the biggest things, validation of the work. I mean, despite the challenges, we're all sort of very passionate and dealing with different issues, but I think that what hit me the most is how we all have different kinds of funding, and some of us have a lot of money and some of us have no money. So that was a wake-up call for me.
Okay, so Velma's concerned about a lot of money, no money, little money. Somebody else? What else did you hear today? What was interesting?
Diversity.
Diversity. You want to tell us more about that, Francis?
Not in the way that it's compartmentalized as diversity is an issue. But the fact of the matter that all of these, it's what the first gentleman said, that we all are facing similar issues in the CHNAs of people who are in outer lying areas that are different from the ones that are the hub. I particularly heard from a woman named Edna, is she in the room? Where Framingham has issues of Brazilian and Latino and African American communities, and then outer lying communities are less diverse, where they have language and transportation and so forth. I didn't hear the word racism today in any of these discussions, and that was something that was absent that I thought might have been said. It may suggest that it's still a charged term, sort of like terrorism. There are kinds of things that we don't want to talk about, or we don't exactly know what to do about it, so we sort of put it in a frame. But the other thing is, I learned from a nurse, somebody who's a UMass student who's placed someplace, and I learned about her view of what her issues were, which I thought they mirrored the issues when I was learning to be a person who did public health and community health, about food, about transportation, about people who are in places where they can't get to where they need access. So I heard a lot of, I had an education in this. That's an excellent thing. I've done it before.
Thanks, Frances.
That's very well today.
Who heard something unique about a CHNA? Who heard something that their CHNA's not doing, or that was unique and interesting about someone they spoke to? That was a tentative hand up there. Identify yourself, please.
My name's Caitlin Aber.
Caitlin, can you stand up and really use your diaphragm?
Yes, I'm short, so you need to see me anyway. My name's Caitlin Aber. I'm from CHNA 17. I heard about a CHNA that has a kind of council of community members that they've given funding to talk about kind of how they can be advocates for the CHNA on the community level. And I think that a lot of the CHNAs have representation from the organizations, but not the actual community members being served by those organizations. And I thought it was a really unique idea and a great way to stay connected to the actual community members that we're serving as opposed to the providers.
So who is the CHNA that's doing that? Okay, what CHNA are you?
CHNA 9.
Where are you?
Leominster, Fitchburg area.
Okay, so you want to know more about that? What's your name?
Selena.
Selena's the person to talk to. Something else you need, go ahead.
I'm Liz, also from CHNA 17, and also about CHNA 9, that they have someone from Walgreens that participates. And again, it's like, who do you invite to the table? And why wouldn't you invite, like, a pharmacy? It makes perfect sense to me. So, we'll talk with our CHNA about who do we invite.
Okay, so Walgreens at the table.
David Aronson from Boston. I heard about a CHNA that does not give any mini grants, but actually hires staff to carry out the work with their partners. And one of the reasons that they do that is that they feel it's much better and easier to keep, to be accountable for what happens, rather than giving out mini grants and trying to figure out what happened to the money and what the outcomes were.
So who is the CHNA that's giving out mini grants? That's giving out paid employers?
Yours.
Okay, mine, and Marsha Picard is the person to talk to. Marsha is actually an employee of the CHNA, so you get a full-time employee, so you can find out a little bit more about that. Somebody else want to add? About something that's unique that you heard or interesting that you heard? What about the visioning? What would you do if you had all the money? What were some of the things that people said to you if you didn't have any money restrictions?
Patty Jean Martin, CHNA 23, from the Plymouth, Rockland.
Okay.
Sorry. Patty Jean from CHNA 23, from Rockland to Plymouth area. We had a lot in common, access to care. We definitely would make sure there was money so that everybody had access to getting adequate health care and mental health, making sure those were two big keys, and we were both very, had that in common. So it was nice to see that we all have those common values.
So before I turn back to Steve, I think we're going to go to a little break for a couple of minutes, but before we do that, I just want to say I'll get up on my soapbox, and when you get to be the facilitator, you get to say what you want. So, until Cathy comes and pushes me away. So my soapbox is this. We could be incredibly powerful. You know, whenever I do this exercise, I always worry that people aren't going to talk to one another. but it was clear that everybody in this room was like an alpha person. There was conversation, and you wouldn't even move, and you kept on talking as you were moving your bumps from seat to seat. You kept on talking to one another, because not only are we knowledgeable about what we're doing, and not only do we have power in what we're doing, but we are passionate about what we're doing. And the only way change comes about is that combination of knowledge, advocacy, and passion. We have an opportunity now. It's the first time the state has met this way. And we have an opportunity now to harness our ability to connect, to reach out, to influence what DPH has to do, and to change the way we view health and well-being in the future. And we are on the ground floor. This is as grassroots as it gets. So I encourage you, as we move forward, exchange business cards, connect with other people. Let's keep the conversation going, and let's find other opportunities so that we can share the great work that we're doing. Thank you. 10-minute break. 10-minute break.
So what I wanted to do, again, for those who may not know me, my name is Steve Ridini. I'm from Health Resources in Action, and I'll be facilitating the rest of the day. The conversations this morning were really interesting, and we want to continue these conversations and to really engage you in some interactive exercises. Before we go there, though, I wanted to give you a few of my own observations of what I've heard from the conversation this morning. This won't be an entire list, but a few things that I felt like stood out. One is, I think it's important to recognize the loss of what you may be experiencing, both in terms of either staff from regional centers that aren't there, and I could say that as one of a regional center person who used to provide a lot of training in TA to CHNAs, or other types of loss. I also think, going back to the woman, I think, from Springfield, and what I heard from a few others, it's important for you to all articulate what it is you're passionate about, your vision for this work, the guiding principles, as well as that you're change agents, and you're a voice for change in this state, in your own communities, but in this state, and to continue to articulate that in as many settings with as many people as possible. I also, what amazes me, thinking about this from a community development point of view, is the sustainability of this work, with very little in terms of funding or resources coming from a centralized place. When you look at this work, though, at the local level, and I use local and regional interchangeably, there are a lot of resources. And as Frances said, if we think about resources beyond funding, but think of them in terms of people, in terms of in-kind support, and however you define resources, you are stories about sustainability. And those are incredible stories. And it actually may be interesting to think about how do we write some of those up and think about lifting up this work. At the same time, we are in an incredibly changing landscape in terms of with healthcare reform, in terms of what's happening with public health departments thinking about accreditation, with nonprofit hospitals thinking about assessment work, about clinical community partnerships. Quite honestly, I travel the country and people talk about the notion of community engagement, and I don't know that they understand entirely what that means. So there are a lot of folks using the words partnerships and collaborations, and yet the money is going for outcomes. It's not going for the backbone support to support the collaborations and the partnerships. So we have an opportunity in this state, as a leader, as we've always been, is to talk about what does that backbone support really take. And when we think about resources, what does it mean to achieve health outcomes through multi-sector partnerships? And to think about both process and outcome level indicators. The tangent I'll provide to you right now is I'm currently working on a project with the Centers for Disease Control doing just that. As we're thinking about health outcomes and health indicators for a lot of our assessment work, what the CDC is asked is who can talk about process? Who can tell us a little bit about what it takes to move these outcomes to a different place? And that's what we're beginning to do. We're actually shaping a whole matrix of indicators related to process level indicators to move the needle on outcome level indicators. So that's something that we're working with CDC and their community transformation grantees on, which I think would be really exciting. I also, the observation that DPH, and I said this in my brief comment, is that DPH is articulating a strategic direction around community engagement bodes well for all of us in terms of thinking about what this means. I also heard, though, that something is going to change, that DPH is not going to require people to come to CHNA meetings. I'm actually thinking that's not such a bad thing, because when I was in Southbridge, there were folks that didn't want to be at the table. But as this woman here from Cape Cod articulated, is the folks that are still coming are coming because there's a reason. There's something they're getting from it. There's something they're contributing to it. So that's something for us to think about. And then ultimately, the ultimate goal of this work is building healthy communities and improving population health. So as we think about all of those things, those are just some observations I have that will lead us into the next piece. I wanted to turn it over to Eileen for a minute because she had a few observations too before we get into vision.
Thanks, Steve. And I'm just going to make a couple of quick comments just as after I was sitting down and thinking about all the questions, things I wish I had clarified a little bit better. And then again, at the end of the day, glad to take more questions and talk to people during lunch. So the new Office of Local and Regional Health is very much in early formation stages, shall we say. So, you know, lots of different conversations are happening in the department, and conversations will be happening with the regional directors. And the vision really is to be providing support to the community. So I think the advantages for all of you is being able to interact more closely with the local boards of health and other bureaus at DPH. Versus the work being as focused just on CHNAs. There'll be a chance to really bring people together. Right now, we have over 3,000 employees at DPH. Half of them are in the hospitals. The other half are doing work that often impacts the community. And unfortunately, our work is often in silos, and there hasn't been good collaboration across the department. And part of this new office, the goal is to actually get the resources from the various bureaus at a better level down to the regions, and to get the staff in the regional offices to be collaborating more effectively, which is not something that perhaps was a high priority of previous commissioners. So this will actually help the regional directors be able to I think, serve more effectively as a liaison and kind of a clearinghouse of all the resources at DPH that could benefit your community. It's going to take us a while to figure it out. It's like kind of moving an ocean liner. We're not going to have answers overnight. You're probably not going to see radical changes in the first couple of months. It'll take us time to figure things out. It'll take us time to get good systems in place. But that's kind of the vision that we're moving towards. Something that hopefully will lead to more opportunities. And then again, in terms of the defining resources, the best practices that you are all talking about here today is exactly what we do want to support. And what is the training and TA and kind of partnership support that is needed to support those. And so what I really encourage you to do is to identify for us what is working so that can be clearly supported. And that's all I'm going to say right now. I'll turn it back over to Steve to help you all figure that out. Yeah.
Okay. Yes.
Will this be the only conversation that the DPH has with this group?
Will this be the only conversation that DPH has with this group?
I don't know how often this group meets or what the plans are, but certainly glad to come back and our goal is to continue the conversation. The next step for us is both we have to talk to our own staff. You've actually seen something before most of our staff have, with the exception of the regional directors. And we are going to be doing these community dialogues. As we gather that information, meeting with all of you again to kind of process what we are finding would be very helpful. So I don't know what your plans are for a meeting schedule or anything like that, but...
This is our first time ever meeting.
Okay, well then,
we haven't gotten that far.
That's part of what could be discussed later in the afternoon.
Yeah, so that could be kind of a next step. But one of the most immediate next steps is we've got 8 of these dialogue sessions happening. Know when they're happening in your community and bring folks from your CHNA and your coalitions to these meetings to dialogue, okay?
And that schedule should be available by next week.
So what I wanted to do is set the frame for this next exercise, take a break for lunch, and then think about the afternoon. And so this next exercise is a little bit about visioning. As we've probably all realized in our work, you need a vision, correct? Think about the work that you've done where you didn't have a vision. And then think about the work you've done where there was a vision. Which was more effective and sustainable? I see a few people shaking heads. Which one? Why? Visions are a pain in the neck. You got to get everyone to agree to something. You had a direction. And so the beauty of this is, I'm very much a visual learner. If we think about visions as kind of these circles, the vision is where these circles begin to overlap a little. If you think about a Venn diagram, who thought you would have been doing math today? But if you think about where those circles begin to overlap, that's the shared purpose, and that's the vision. And quite honestly, what the literature tells us, as one who has studied community development theory for 12 years in school, what the literature tells us is if you have a vision, that's probably going to be one of the number one things that keeps a group moving in terms of sustainability. Not even resources, but it's the collective vision. And yet, again, what we find is people don't spend a lot of time visioning, oftentimes because I think funders don't understand the value, the real fundamental value of vision. So when you bring divergent or diverse individuals or entities together, to take the time to think about vision is really important. So what we're going to do now is many of you probably already have a vision for your CHNA. You even asked a question during this exercise. What I'd like you to do is sit with other members of your CHNA and answer a question around vision. Because that vision question and how we share that information with each other will then help us think through some questions, or the major question this afternoon, to help us think about, so what resources do you need to achieve and realize that vision? Okay? So those are kinds of the two questions. One is a vision question, and I'll put up the wording in a minute. The second is, what kind of resources? And if we think about resources from that lens of not just about dollars, but however you want to define resources, what kind of resources do you need to successfully achieve or reach that vision will be what we talk about after lunch. So the question around vision. And again, I'd ask you to think about maybe doing this. Actually, I would ask you to do this individually first. Because I also find this as a really interesting exercise when I work with coalitions, is when I ask people to do visions individually to see how closely they're aligned with other members of their group. So the question is this, moving forward, what's your CHNA's vision for building healthy communities and improving population health? There's no right or wrong answer here. So take a minute or two to answer this, and I'm going to ask you to find other members from your CHNA and have a conversation. Okay, they are? Okay, so I'll figure that out. So the question is, for those who want to hear it one more time, moving forward, what is your CHNA's vision for building healthy communities and improving population health? So what I'm going to ask you to do first is a minute or two of writing on your own, and then find your group. If you're here by yourself, let me know and we'll figure out. Okay. All right. I realize some of you are starting that are still writing, but what I'd like to do is not get in the way of lunch either. So why don't we won't require it, but my hope is, knowing the energy in this group, you'll probably all want to contribute, which is really good. What I'd ask you to do is stand up in your area with the other members of your CHNA, and I'd like you to just share some of your thoughts. And if you could keep it to like about a minute or two. Who wants to start? Okay. And again, you're from the Cape
Islands, 27.
Okay, others.
So, really what we were talking about in a vision was more broad than just about improving population health and healthy communities, but we came up with the creation of a hub that provides space for shared learning, collaboration, networking, cross-issue interaction that ties together efforts to improve overall health. And it's the World Health Organization definition of health, not just our physical health, for the community and all of its members. Cool.
Both physical learning space.
Yeah, I like it.
Good wisdom.
Yeah, I'm going to take, as you're done, I'm going to take them and put them up. So thank you. Another group. Just stand up. Okay.
Oh, I didn't know you guys had to do this too.
You're right.
CHNA 6 Milford, making Greater Milford the healthiest communities in the state for communication and collaboration.
Great, so you hear the concepts that are emerging from these. Wonderful, thank you. We'll put that one up. Another group. Yes,
We are CHNA 15.
where's that?
We are northwest.
Okay.
We have a vision statement. We've been in the process of revisiting it. So this was perfect timing for us. This is what we do. It's to create an environment, incubator, space that brings together service providers and those being served to collaborate, inform, and build capacity, and thereby build healthy communities and improve population health.
Fabulous, thank you. I'm going to leave these up there. We'll take them. So you can look at them at lunchtime. Thank you. Next group.
Sure. Hi, I'm Frank Conley with the CHNA 17, Cambridge, Somerville, Watertown, Belmont, Arlington, and Waltham, and the Regional Center for Healthier Communities out of the Mount Auburn Hospital. So we don't have a statement per se, and we did go through a long, arduous assessment and process to get us where we are today. So currently today we're working on 3 areas, food and activity issues, mental health, youth-related health issues, and safety promotion / crime. So it's really 3 areas that we're really helping to sustain right now as we speak. I think one of our visions going forward, we'd like more collaboration with our partners, with the hospitals especially. Like to have a louder voice. That's me speaking now. And more inclusion and reciprocity with the stakeholders.
Thank you. Again, listen to the concepts.
And can I, I'm sorry, can I just add, if you're talking about vision, we would not be able to do the work we've done without a coordinator who's paid to do the work, and without the technical assistance of the regional centers that we're fortunate enough to have help us. So,
great. So those 2 ideas, the technical assistance, the training, the dedicated staff, when we get to the resource question later on today, those will be some answers. So hold that thinking. Kim.
So some key points that our group, and I'm with today, CHNA 7, which serves Framingham, Greater Framingham, as well as Foxborough. Diversity within our organizations to make sure we're impacting all of the individuals, because we do at all of our communities, but especially in our area, have such diverse populations, and making sure that we're having of those individuals represented. Connecting was a big word that we kept coming up with in terms of connecting resources. We have so many different organizations that are passionate about so many different areas of public health that we can't all be experts in those areas, but we're hoping to bring such a diverse group so that we all know where to send our individuals that are representative. And collaboration, so that we're working all more efficiently. Time and resources are a consistent theme that all of our organizations are struggling with. So if we work together, because we all are passionate individuals who are excited about helping and creating healthier communities, we need to use our resources together to be able to impact.
Great, thank you. Those are wonderful. Another group. Yes, Peg.
We have 3 community health networks here at the table, so we have just sort of themes, not individual visions. So this is CHNA 1314, the North Shore Community Health Network, CHNA 9, which is Fitchburg, Gardner, Leominster, and CHNA 22, which is Brockton and Walpole area. So some of the themes we talked about were working towards a common health agenda, addressing health disparities in most vulnerable populations, developing health equity in all communities, advocating for health outcomes and systems change, being a premier voice for health in the region, key words there, to harness, leverage, or create synergy in one direction to achieve impact outcomes. So,
thank you. Thank
larger vision.
Yep, love it. Yes, please.
Patty Jean Morton from CHNA 23, which we take care of Rockland, Hanover, Hanson, all the way down to Plymouth. So we have 12 communities that we serve.
And right now, we do not have a vision statement, but we are looking at our health literacy assessment that's being done, and we'll be creating our vision statement from that. And what we are looking at and hoping that the direction of our vision statement would be is health literacy will be leading to people in our communities to understand in their health care in order to follow and understand their role in their own health care, because we find that that's a very much needed need.
Thank you very much. Another group. Okay.
So we were CHNAs 5 and 8 working here together at this table, which is Worcester, and the 8 surrounding towns is CHNA 8, and then CHNA 5 is South County, including Southbridge area. And so some of the common themes that we found between our vision statements are the idea of coming together and unifying voices, linking providers and researchers and policymakers, people and institutions, lots of different ways to think about unification. But that something important is finding a common plan so everyone's rowing in the same direction. And also that we all believe strongly in using a broad definition of health, better use of talents and resources, and using an asset-based approach.
Thank you. Another group. Yes.
Should we ban our white?
Doing it well.
We're at CHNA 11, which is the City of Lawrence Mayor's Health Task Force. It's weird because we started as a City of Lawrence Mayor's Health Task Force, and in 2010, DPH asked us to sort of absorb CHNA 11. So we talked about a lot, but it seemed to me that the core of everything we talked about was really related to engagement and participation. We have a lot of people at the table, different levels of commitment. So I think that that true participation highlighted here and the engagement from all sectors of the community is needed. When we talk about community, we're talking about residents and engaging them in the work that we are doing in some shape or form, and to educate them around public health and you know, the benefits. Businesses, we have a lot of businesses, and now we have this group that's meeting, that's mimicking the Lowell plan. So I'm at the table trying to get them to sort of look at what we're doing over here. Don't start nothing new, because there's a lot happening already. City government, we sit within community development, but we get no funding really through community development. But it gives us access to a lot of things. So we're starting now the conversation in the planning and community development, starting to look like health equity. And we recently had a press conference for a healthy active living resolution that's going to help us get the buy-in. Academia, we're good at that, but we're getting other people to learn about how to do CVPR and be part of it, security groups, et cetera. But the action, I think the core thing is, we serve Lawrence, Methuen, Andover, and North Andover. Obviously, the city of need is Lawrence, so a lot of our work focuses there. So until we figure out the poverty level, we start addressing that. The unemployment rates and underemployment rates, until we figure that out, we're not going to move anywhere. Workforce capabilities, we have a lot of new immigrants with, you know, with need of different needs, soft skills, any kind of needs. So we're looking at that. Training, certification, a lot of professionals that can do their work here because the recertification process, they're not aware of it. Awareness raising, policy makers at the table. So you see this improving community, chronic disease self-management. There's people who are living with this a lot in our community, so we can't fix it. So we just have to teach them how to live with it. So that's one of the things that we're looking at. And the perception and the reality around safety in our city, that's stopping us from using a lot of the parks. We have like 43 parks that are available to our community. So we're looking at all this.
Great, thank you. Thank you both. Wendy?
So we are the New Bedford CHNA and the Fall River CHNA, which is made up of 13 different cities. We run from Somerset, Swansea, all the way to Wareham. So I need Vanna White. Okay.
There are resources.
Promoting strong leadership. We tend to see the same people, and we worry what happens when, as we are getting older, who's going to fill the gaps and how we engage in new people for leadership. Working with diverse members who have diverse ideas. It would be nice if everybody came to the table and thought exactly the way I did, but they don't. Creating healthier communities by involving the participation, energy, ideas, resources, and intentions of all community members in all sectors. Connect, collaborate, and change for healthier communities. And bringing new superstars to the leadership, superstar organizations and superstar individuals.
Great, thank you. Thank you very much.
Hi, so in Boston, we've been going through a large planning process. So we created a vision for what we saw as a healthy Boston, and then have come up with 5 particular issues that we're going to focus on, which are health equity, better connection between healthcare and prevention, community resilience in the face of trauma, focus on social determinants of health, particularly education and employment, and involving newcomers and immigrants in community decision-making processes. And how we think we're going to get there is through having collective impact, because we're going to have some shared goals in each of these issues. All of it is framed through a racial justice and health equity framework. There will be empowered individuals and coalitions and organizations. We're going to develop a better advocacy capacity, and we're going to try to have better collaboration with hospitals in particular, since we have 13 of them in Boston, and other sectors.
Thanks, folks. Another group? Yes.
So I'm Shauna Wallace, I'm the coordinator for CHNA 18. Shauna Wallace, I'm the coordinator for CHNA 18. I'm the only person here from my CHNA, so I had to kind of guess, but I've worked with them enough, I think, to say that overall, for as long as I've worked with them, they do have a vision statement. I could not recite it for you, but basically, everything they do is focused on utilizing community resources by promoting collaboration. So it's using what already exists in a community and supporting improved collaboration among all of the community organizations in our town. So, by the way, which are like the western suburbs, Newton, Wellesley, West of Dover, Waltham, Brookline, I'm missing a couple. But that's really what our basic vision is. So we're not new and innovative. Our goal is to support what's already happening and encourage the groups in our community to come together and collaborate with resources. We do that through granting, we do that through all of our community meetings, and everything we do, that's our overall vision to improve our health. We do have specific health goals. We did a large needs assessment, but really our greater vision is supporting what's already there by improving what's happening.
Thank you very much.
The western suburbs, Wellesley, Newton, those groups.
Not to be disparaging, but years ago, Sean Fitzpatrick made a CHNA dictionary, and they called that CHNA the Chenapple.
What's going on in Springfield? What's your vision?
I'm Michelle Morgan from Springfield, Michelle Morgan from CHNA Board, Greater Springfield. I'm a resident, a long time born in Springfield, now I'm a resident of Northampton. Just collaborating and bringing communities together because we don't have a CHNA there. We have various issues in all of our communities. I believe you have 14 communities. And all of our issues are different, all of our communities are different, but we have these basic same needs and necessities, and we've been working towards these goals for quite some time now, and we think they're worthwhile maintaining, and we've made great strides in them. Greater Springfield CHNA will continue to engage in honest conversation to deal with the continual process of pursuing access to maintain relationships which ensure and assure educated, literate communities. All people thriving and flourishing free of bias, embracing health, the basis of life at every moment. Also, to continue the access to fresh food and health care as we engage the minds of our young by energizing activities that increase their wellness. I'd like to add before when we deal with the youth, we have the Springfield Adolescents Health Project, which does great work. I'm sure that you can find us on the web through the Department of Health at some point. And they are the heart of our efforts.
Thank you. Thank you. Any other groups? All right. So thank you for taking the time to kind of put down on paper your vision, either in eloquent statements and or concepts. What I'm going to ask you to do now is nourish yourself, grab some food, and we'll take a break for a little while, then we'll come back and do the next piece. So these were some of the concepts that you had in your vision. Big picture, some a little bit more specific. What we wanted to do now is do something called open space technology. Anyone do that before? Okay, so a few of you. Yeah, the veterans in the field, you've done this. It's called open space technology. And the beauty of open space technology is the issue that emerges is your issue. You also have the opportunity to work either by yourself or with some others. You also have the ability, if you're kind of bored with what's going on in that group, to move to another. But what we need you to do is, as you're thinking about that issue, is to help think through, so how would we resolve that question? And so up here we identified some common themes or ideas from this morning. So you may want to take one of these themes as we think about moving the CHNA work to accomplish your vision. You may want to take collaboration and answer the question, so what kind of resources do you need? And thinking about Francis's idea of resources, not just about money, but thinking about resources broadly, what do you need to address the issue of collaboration in your particular municipality or community or region, CHNA, however you want to define it. Your issue may not be up here. So that's also the beauty of open space technology. You are a vocal group, and you can pick something that hasn't emerged. What I would ask, though, is you to take a minute to think about whatever the issue is. So again, we talked vision. The question I'm asking you now is, what resources do you need to accomplish your vision? So in thinking about the vision, I'm asking you to maybe focus on one particular emerging theme that's either up here or one that you have in your head. What I'm going to also ask you to do now is, if you know what that issue is to stand up, call out that issue, and then I'm going to ask if there are any other folks in the room that want to work on that with you. And we're going to do that until we identify all the issues. And again, so you identify the issue, we're going to do that now, then you answer the question, what kind of resources do we need to accomplish that? Okay? It's as simple as that. Who wants to start? Now don't all get shy on me now. Anyone? Feel free to stand up. So this is the, no, this is good. Thank you, Elizabeth. Elizabeth is interested in engagement participation. Anyone else? If you are, follow Elizabeth. You will get a piece of paper and then answer the question, what resources do you need to kind of fine-tune or perfect engagement and participation? Thanks, Elizabeth.
Communication.
Communication. I heard, I knew there were some other folks that had communication. All right. Pat, you want to do communication too? Okay. So go for it. What do you, David, what do you want?
Funding and the determination of need process.
Okay, so if some people want to follow David. Funding and DON. Okay, so we've got engagement, participation, communication, funding, DON process. Edna.
Health equity?
Please stand up. Health equity. Okay. Jamia, you're going with Edna. Anyone else want to go with Jamia and Edna? Feel free to. Okay. Anyone else? Yes. Let's hear, let's listen.
I'm not, it's kind of all over this, but it's sort
That's
of
okay.
making, sort of understanding population health for the layperson, the everyday.
So I need others. Understanding population health from a layperson perspective. Okay, follow Lisa. Yes.
Shared vision for collaboration.
Feel free to stand. Wendy, shared vision for collaboration. Love it. Okay.
Racism.
Teresa. Say it out loud so I can hear you.
Issues related to racism.
So Teresa wants to work on issues related to racism. Okay, feel free to grab a piece of paper.
Where is the paper?
Anyone else?
Hey, we got the team going now. I'm sorry I have to give you two, but if you don't know
Thank you so much.
And for me, I sometimes feel like I'm being this like principled little old lady saying, but process. But I feel like if the process is that the hospital can do that, let's say that's the process. Okay.
If there's someone from each of the groups that could report out, again, remind us of what your topic area was, but then to give a little bit, like a 2 or 3 minute summary of what your group talked about. We will take all of these notes from today, type them up, and get them back to you, okay? So who would like to start?
We had a very exciting conversation over here. Engagement and participation. And I'll just read right through what we chatted about. The resources that we need. Leadership. A common statewide name. I don't know if I need to elaborate on that at all.
Not right now.
A list of DPH contracted vendors. Statewide website linked to the individual CHNA websites. Updated list for boards of health and health department contacts. Celebrate 20th year anniversary. And I think we talked about, where's Ron? Statewide. Wouldn't that be lovely? Have a statewide celebration for everyone's 20th. Communication between boards of health and the CHNAs, and steering committee committed outreach.
Great. Anything else from this group? All right. Well, thank you. Oh, go ahead.
I just have one other thing. I think what's important is that what I'm learning from other groups that are here is you don't necessarily have to have too many meetings. Sometimes we do have too many meetings, and then participation tends to diminish over time because we have to respect the value of the time of the people that are making the commitment to be there. And I think I think when we go back, one of the things I'm going to question is whether or not general membership should meet monthly or should it be bi-monthly, as some other people are experimenting with, so that you increase the level of attendance and participation, and you make those encounters more meaningful. That's just what I'm thinking.
Great. How about a round of applause for this group? Thank you very much.
I sort of feel like we're a little bit out of the norm of conversation here, and that we kind of opened a can of worms that is just the starting point of a conversation. But the issue was the use of the term population health. And what does that mean? What does that really mean in sort of how we're starting to think about it and use it now in our work and in healthcare and all over the place? And so we had a really lively conversation, and I guess the only outcome really is to maybe just say it out loud that the use of the word population means different things at different times for different reasons. And when we're thinking about healthcare delivery, we sort of moved away from the concept of community health, and we're now talking about population health, but at times it means very specific populations, not our overall population. A cohort, a set of practices, a population might be those that have Medicare, Medicaid, those that have diabetes, those that are women, those that are young and healthy. And so I guess just this is a much bigger conversation for its own conference probably. But it's just something that has continued to resonate in me, conversation after conversation, is who are we talking about when we're talking about population health?
Anything else from this group?
Yeah, well said.
Ms. Francis.
Who are we talking about and what are we talking about?
Great. How about a round of applause? Thank you. All right. How about this group? Is there someone that wants to report?
We got a code report.
Okay.
I know you're such a collaborator.
I don't know if this will help you.
You want us to hold it up?
Okay, we had the health equity issue, and so one of the things we did in opening was to make sure that we all understood what we were talking about, because that could be a lot of things. And as we went around around the circle, we found out that language, and a lot of things came out of it. Language not meaning like a foreign language, but language in terms of health language that's used, terms that are used like minority, which should not be used anymore because the minority is now the majority. So are we going to switch to the majority population, and that becomes powerful? But stuff like that about language and how that can impact the way institutions deliver health care. We talked about institutions looking at, for instance, me as an African American, or Selma, being Latino, that one definition is applied to all. And you cannot look at me and know what Africans are like, Caribbean people are like, and so forth. So it's a matter of being sensitive to the individual cultures that you're dealing with, not determining that you have a cookie-cutter approach to dealing with all people who are black, or all people with Hispanic surnames. You just can't do that. So we started out sort of taking some of the issues that we thought related to it. Racism definitely was a part of it. And so we talked a little bit about racism and how that impacts the delivery of health care. Not always malicious or deliberate, but it happens. And it gets to be institutionalized so that it's just a way of going on, and then people think that's normal. So we talked about that. And then we tried to get back to the question.
Yeah, but we found that, talking about the issues, what the issues are first is really critical to talking about the resources that we needed.
Absolutely. So when we got to the resource issue, we talked about the behavior of people, and basically we're asking that people change their behavior. That's like major. And, that's like saying I'm going to be a rocket scientist when I haven't finished grade school. But that is one of the main things that should be an objective, is that we work to change people's behavior so that any group presenting themselves at an institution can feel that they are going to get the same service, not based on any outside opinion or any kind of racist behavior or thought process that someone may have. But if I walk into a hospital, I want to know that I'm going to be treated the same thing, not having, in many cases, for instance, as African American as an example, where African Americans were not offered certain cardiac procedures, and so they didn't get the same level of care as a Caucasian that walked in with the same symptoms, everything. So those that we felt that racism was sort of the foundation of a lot of problems in health equity issues, and this is an ongoing thing. We don't assume that it's going to be solved with one little training set, a workshop on racism. We don't anticipate that.
And so we talked also about, in terms of resources for the CHNAs, about how we can kind of continue all to develop a kind of foundation in racial justice theory so that we're being more inclusive about our strategies for getting outreach, getting people to the table, making sure people feel comfortable. So instead of using terminology like minorities, we're using terminology like people of color, or being even more specific. If you're going to be talking about, Vietnamese population, speak to that, don't use code words. And so we talked about kind of, if we're going to be using a training, what term are we going to be using? Because training makes it seem like, cultural competency. Like at a certain point, we're going to be on that level and we're going to know everything, and that's not true. We need continuing dialogues But in order for any of these kind of resources to come out, we need more education and technical assistance on how to be fostering that. And we need mentoring. We need mentoring from organizations that are already doing this work, that can share these best practices on how to be more inclusive and have better language and build capacity and through all of this. And we really need capacity building in this issue. So, is there anything else?
Yes.
I detect a little energy in that group. All right, how about over here? Remind us of the...
Okay, our group was discussing the determination of need process for community health networks and partners. And we started by identifying the basic issue in terms of the issue, and then I'll try to frame it in towards of the vision moving forward, which is what the exercise was about, and resources to get there. Is that there are guidelines for community health initiatives, but they're not working. They're not clear, and they're not necessarily being implemented the same way consistently across the state. I will say it was acknowledged that they were written flexibly, intentionally, and from some perspectives that works, that is a positive thing. But from a community health network perspective involved in negotiating around those community health initiative funds, it's frustrating, and we had people represented all across the state in the group in this conversation. So a couple of the things that we talked about was in terms of a vision for community health networks, we were talking about a council represented by community health networks across the state that would have a voice in any future conversation related to any guidelines around Factor 9 or DON, so that we're represented, we're at the table, and we can provide feedback from a community health network perspective on what the process looks like. There was discussion about accountability for those funds and how that is looked at differently across different partners. And so a council, for example, would be able to make recommendations so that the accountability for those funds across the state can be managed better, and we can look at better outcomes with a consistent way across partners. Right now, the accountability is not consistent across various partners that receive DON funds. We talked about alternative funding sources for CHNAs and being able to strategically align with hospitals that have a role with this DON piece, which is the topic of conversation, but to be able to position community health networks in alignment with the whole Affordable Care Act and accountable care organizations, and being partners in the community with some of these demonstration projects, which in the end may leverage our relationships with hospitals in a strategic way. It puts us in the environment, not fighting it. So that's a resource. It's a way to go about building that resource for community health networks statewide. We talked about community health networks having a resource in terms of advocacy with stakeholders, the Public Health Council, hospital community benefit boards, state and local governments which have a stake in what's happening in their community. We as community health networks need to do a better job with those resources and leveraging those resources with a voice. And also it was recognized that the original intent in terms of DON funding as a mechanism to fund communities based on local voice, and the community health networks in principle serving as that local voice is really well intended. And that resource is something we want to build and keep as it originally intended, but it is related to this process. And I think that covers, the only other thing that was mentioned, and it's similar to Barbara Ferrer's point from the Boston Public Health Commission, for those of you who were here yesterday, is if and when DON regulations are ever looked at, to possibly consider like a per capita contribution statewide that would fund all community health networks for the infrastructure and process that Steve was talking about earlier today that builds that infrastructure across the state. So a different way of looking at UN funding. So those were just concepts in terms of resources, of shifting from being stuck where we are with an issue to moving it to a more productive place with community health networks.
The other thing that I would just add is that we rather than just having the CHNA have a council that would react to what gets proposed, that we think, given that the CHNAs are an essential part of this, the Department of Public Health approach, that the CHNAs, as well as the other partners like the hospitals, ought to be part of the development of the policies and regulations rather than just reacting to them at the last minute.
Okay, we're at communication, and then we'll go to collaboration. Okay.
We talked about communication / messaging. And we were talking about things like how do people get their information. I think, it's evident from all the communication and dialogue that we've had today that there are a lot of people out there doing a lot of good work, but that does not always necessarily trickle down either to the other people that we work with or to the communities that we serve. So we talked about folks that may show up at CHNA meetings. One person gave an example that she met someone that worked for one of the organizations that met with their CHNA, and she had been working for the agency for a number of years and didn't even know what the CHNA was. So, there's a disconnect between some of the work that takes place within the CHNAs as well as getting the information out to the public. How effective is your message? We were talking a lot about language. People tend, who are in the business to use a lot of acronyms and lingo, and you may have people at the table who absolutely don't understand what it is that you're talking about. And one example that I have is right now we're working on an opioid abuse prevention grant that partners municipalities with prevention partners. And the municipalities sit there sometimes with their eyes glazed over because they have no idea what it is that we're talking about. So I think we need to be mindful of using lingo and acronyms, whether we're talking to each other, to new people. So that was one of the things. And is the language that we're using culturally competent? One person was giving an example that it matters even the color of the flyer that you're sending out, that certain cultures associate certain colors with different things. So, and then of course there's the language issues. Sometimes there's just too much information. I know that we got that comment on our evaluation, that there was just too much information that was coming down, and so you kind of get into that overload mode where it's like, what's the information that I need to know, and maybe what's something that I can put over in the parking lot for a while. And then how do you market yourself? So we talked about, in terms of marketing, branding, some people really felt strongly that if your organization had a brand, that people began to associate what kind of work you did with that brand. We talked about developing common and shared language, and included in that would be also a common understanding. So sort of that circling back to make sure what's said is what was intended to be said, and that all folks are on the same page. We talked about orientation and materials, orientation materials for people who were new, who would be joining your group. Just as a way to sort of bring them up to speed and give them sort of a leg up on what the group was doing. We talked about consistent messages, and then also with the orientation, the mentoring piece. So I know the last group mentioned mentors. centers, I think, are really important in just about every kind of work that we do. And then we talked about just some different ways that people would actually get information, whether it was website and making sure that the website was kept up to date, email, snail mail, cell phones, libraries, monthly calendars, translation of materials using class standards, and Dropbox, newsletters, things like that.
Thank you.
Talking about how to bring partners to the table to collaborate, and Alicia gave an example of a mammogram project where she had hospitals and health centers willing to do free mammograms, but people didn't take them up on it because they didn't look at the barriers that were presented to the people that we were asking to come have mammograms. So I think that part of collaboration, what we discovered, is that we have to also be able to identify what the barriers are, have the people that are experiencing those barriers tell us what they need to make the collaboration work. So we understand that collaboration is multi-layered. It is not just the ability to bring somebody to the table. It's the ability to bring somebody to the table, make them feel worthwhile, and to steal a line from Jeff Levy yesterday, he said when you can have somebody feel that promoting your work promotes their work, then you are one step closer to having collaboration. And I think that's what it's about. So we also talked about we're missing the boat because we don't share enough. And I hope today will be the first step in giving us the ability to transfer information from one CHNA to another so we don't have to continue to reinvent the wheel. And then, once again, the advocacy piece. So, quick enough?
Thank you. A round of applause for Wendy and the group. So what I'd like to do is, first, again, thank you all for your thoughtfulness in terms of this exercise and earlier. What I want to do is turn it over to Cathy to talk about next steps, and Eileen.
So I think it was a good day. I hope you all feel the same way. I know you were anxious to get to know each other, and so hopefully everybody met someone they didn't know and had a chance to learn more. So as we heard, and Eileen will talk a little bit more about this specifically, but a few things we'll do is, for one thing, we're going to share back with you the information that we collected today. And so HRIA has graciously agreed to do that. And the other thing was that many people have requested for the one page that you all sent, so that everyone can have that. So we'll make sure everyone gets that, and then we're going to ask those that were not able to complete it to do that if they're willing, so that you can all have that piece of information. And then one thing, so since we are in this information collecting moment and input gathering, surprisingly, how fate has it, the Regional Center for Healthy Communities in Metro West had already thought about a next step because of different work that they had been doing on the planning committee. And so they are interested in doing a collection of, I don't have the right glasses on, so I can't really see good, but I think I'll try. But they're interested in doing a summary document for CHNA health priority areas, strategies used to address these, the funding allocated time frame, how they've been successful, and lessons learned. So what they're going to do is contact you. They're going to try to do this in a brief way. Either you can answer by email or a phone call for those who find that easier. They'll compile this, get back out to everyone, and I think it'll also be helpful to us at the department as we're trying, we're thinking about who's doing what and how you're doing it. And then the second step is they're going to also do some success story collection, which we feel will be pretty important. So that's one of the next steps, and I'll let Eileen talk about the rest.
So we've talked about some things today that are going to take many, many months to actually develop. But in terms of kind of the immediate, we will be posting the survey we did next week, so encourage folks to check our website. We'll also have the dialogue schedule by the end of next week, and I'm sure the regional directors will be getting that out to folks. But both of those will be available on our website and should be easy to find from the homepage. At the department, we're actually going through the process of convening our staff who work with community groups in the different bureaus, as well as the regional directors, and talking about the survey and actually discussing as DPH staff, what do they think? And then we'll be gathering information from the community dialogues. And that process, the community dialogues, will kind of be from mid-November to, I think the last one's like around December 12th or 13th. So then our plan is to kind of work through that information with a small group of people and propose a framework that we can use for moving forward, which, with bureaucracy and everything else, probably will have something, in the midwinter. At that point, what we want to do is get feedback on that framework. So one thought was to reconvene this group to review that framework and give us feedback. We'll also be getting feedback from our staff. And then the commissioner plans to do another series of dialogues in the spring to kind of bring the framework back out to the community and hear from people. So that's kind of roughly the timeline that we're looking at. And then if there's questions in the meantime, folks should be in touch with the regional directors in your region who can answer questions or track down the answer to the extent we have it, because as I said, this is all a developing process, and we look forward to your feedback and your participation. So thank you all, and please do the exercise that Cathy requested, because that information will be very helpful. So thank you.
Great. So you've got some very concrete next steps in terms of some work with Cathy, as she mentioned. We've also got the opportunity to participate in the dialogue sessions, as well as to help put together this framework. Wendy, I think you had one other piece you'd like to talk about.
So first, I'd like to thank Eileen for coming and being part of this and keeping us apprised of what's going on. And to Steve and to Amanda, who came to so many meetings and listened to us moan and groan and really made this happen. And to your entire staff, kudos and thanks, because I think it was great. And especially to Cathy, who has the vision and the tenacity and the courage to really let this happen and to this go forward. I'd like to propose that as our first advocacy, we put together a white paper about why we think CHNAs are the way to go. And Fall River is willing to do some authorship on it and then send it out. We will use the notes from this meeting. We will send it out, and then if you and your CHNA would like to sign onto it, we think that would be a great first step. So thank you very much, and we look forward to our continued work.
So I think we kept you slightly over time, but I can't end today without doing something I know was near and dear to Peter's heart, which was to do a little assessment of the meeting. So, sort of our plus delta. What? Oh, I know we are over time, right? Are we not? We are? We have 5 minutes? Oh, we do? Oh, okay. Oh, just 2 clocks. So, yeah, and, because it's really important. I know he always found that important. And the other thing, I was just reflecting on one of the things that he thought so much about, and we didn't talk too much about today, but is really clear and present in this room, is the value of relationships and how much they mean, and how much once you have established those relationships, that's what really gets business done. And the ways that he always went about doing that in terms of getting to know people at all different levels, not just at their job level. And so I know all of you do that and practice that, and I encourage you to do that in the future. So let's start with, how do you start? I always like to start with, I like to end with the positives. Although usually you do start with the positives, right?
Start with the delta.
All right, so we'll start with the, so because I want to end on the positive today, can we start with, what's something that you felt could have been improved about today? Just a shout out. Clara.
More time for discussing sustainability of CHNAs.
Okay. more time to discuss sustainability. CHNAs. Anything else? Teresa.
Adding on to that time, there's a lot covered. You know, part of it is just time to get to know each other, time to learn what we do, but then there's also what's going on a state level, which is a whole lot that needs time in itself and time to talk with us about that. So a little more space in that, and then other things as well. So that would be one of the.
Great.
I thought that the visioning process, although it was good, I think it was too brief. I think that perhaps that's something that could have been begun before we came here. We would have been more prepared.
Okay, good idea.
So, yeah,
Yeah.
because it's an important question.
Yeah, thanks for that. Yeah.
Just an add-on to that, I would have liked to have seen something where we worked more on the visioning, something where we worked more on what was common for all of us as opposed to focus so much time on our own vision.
Okay. So the idea was what can happen in the future is to look at what are the commonalities among all the work that you're doing. Anything else? Sorry, one more. That's it.
We need to meet again. I don't think this is one time.
So change the fact that we might not meet again, too. We might meet again. Okay.
Yeah, we
All
need
right.
to meet again.
Okay. All right. So what did you like about today? What felt good? Sue.
Cathy, the fact that we even have this is terrific. Massachusetts is a leader publicly in the way that it designs its public health policies. The fact that we have CHNAs, we are ahead of every other state in the union, and I applaud DPH for just having it.
From Oregon. I've only been part of this for the past year, and I've just like a side note, I guess, but I regularly think about when I move back home how this is something that I could possibly implement out there, because I think Massachusetts is like really ahead of the game in a lot of areas, and I think this is an impressive organization.
Great. Thanks, and you'll have a lot of people to help you. You'll have a lot of people to call up.
Yeah.
Deb.
So I really liked the speed dating piece, but I wish the questions had been broken down individually.
Yes.
So that there wasn't like, because each question seemed to be like a three-parter, and the time frame that you had was not enough.
Yeah.
So if they had been broken down,
Yeah.
and you had more partners to answer that with.
Yeah, great.
Meetings and conference, was it worth the time spent away from work? And it's a definite yes.
Is that it? Okay, all right. David.
I really appreciated Eileen for being here, because I know she's got a lot to do, but to me, it signals that DPH has an investment in our success.
Yeah.
And I greatly appreciated those of you who stood up and spoke with clarity and eloquence about the work and value of CHNAs both locally and statewide. It's great to hear a unified voice coming together about our ability to move forward and accomplish things across the state. So thank you all, everyone who stood up and spoke.
Thank
Thank you for having Steve here as our facilitator. He's fabulous as always.
Yes, thank
Very
you.
helpful.
I also wanted to thank everyone here. I really learned a lot. I met some wonderful people. Had a reflection while I was sitting and listening to people talk. And as you had mentioned, this room is filled with people with the deepest commitment and the deepest regard and are strong. And this is a group of people that really is doing great work. Will continue to. So thank you for all that you've shared today. It's really been a great process.
So since I have the mic, I guess I get to also say what I thought was positive about today. And I really appreciate the energy that you all supplied to this. You are volunteers to this work. You put a lot of time and commitment and thought into it. You've spent a lot of your days, weeks, months doing this for the good of your community. And this is what makes me get out of bed every day to go to work. So thanks.
And before we go, I just want to recognize Cathy for being